Al-Fatihah. Okay, apologize to presenters, saya tak sempat review lagi your slide. What are the topics for today? Problem based kan ya? Hello?
Yes, problem based.
Yes.
Oh ya, lymphadenopathy, hypertension and rash ya. Okay, alright. So we have it is a common situation in pediatric clinic as well as in the ward ya. Patient come with this kind of features ya, signs. So let's discuss one by one ya. Okay, who will present first?
Okay, I will present the first. Before that, I would like to apologize because I couldn't open my camera due to unstable internet connection. So today we will proceed with PBS. So today we will proceed with PBS 3, child with lymphadenopathy, child with hypertension, and child with rash. So I am the first presenter. My name is Nurul Izzati binti Hisham, 1619618. And I will be presenting about child with lymphadenopathy. These are my outline for today. Next. So this is the introduction. So, what is lymphadenopathy? Lymphadenopathy is defined as the enlargement of lymph nodes, and it occurs in a variety of infectious, inflammatory, and malignant processes. This is from the Nelson Essential of Pediatrics 8th edition. Lymphadenopathy can be classified into generalized and regional or localized lymphadenopathy. For generalized lymphadenopathy, it is an enlargement of two or more non-contiguous lymph node groups. So the right side is the infectious causes of generalized lymphadenopathy. So as the name goes, generalized lymphadenopathy is usually will come together with systemic causes, systemic symptom. So the next one is regional lymphadenopathy is an enlargement of only one lymph node groups. So this is the infectious causes of regional lymphadenopathy. Next. There are three terms that we need to familiarize with, which are the lymphadenitis. It is an acute or chronic inflammation of lymph node. The second one is lymphangitis. It is an inflammation of the lymphatic system itself. Usually can be caused by Staphylococcus aureus or group A Streptococcus. So the third one is the lymphocutaneous syndrome. As the name goes, it is a lymph related and cutaneous, also skin related syndrome. It is a regional lymphadenitis associated with a characteristic skin lesion at the site of inoculation. So one of the example of lymphocutaneous syndromes are cat scratch disease. So next. So what are the etiologies of lymphadenopathy? So these are the groups of lymph nodes, and the most common causes of lymphadenopathy in children are at the cervical side, cervical area. There are also axillary lymph node and also inguinal lymph node. So next. So the etiology, as what has been mentioned before, is caused by infection, inflammation, or malignancy. So so by infection, so lymph node actually in lymph node they have lymphocytes. So this lymphocyte will filter the lymph fluid. So if there is any antigen presented in the lymph fluid, this lymphocyte will trigger the immune response, thus causing the cellular proliferation and lymph node enlargement. So for malignancy, it can be caused by primary origin or secondary to metastasis, and the cancer cell will reside in the lymph node itself and causing lymph node enlargement. So the third one is rare lipid storage disorder. It is a lipid storage disorder in which there is an abnormal accumulation of lipids in the liver, in the spleen, in the heart, in the bone marrow. So one of it is Niemann-Pick disease. So next. So what are the differential diagnoses? So before I proceed with the approach to the patient with lymphadenopathy, we need to have several differential diagnoses so that it will make us easier to diagnose the patient. So one of the common causes of lymphadenopathy is tuberculous lymphadenitis. So since our country is very common with TB infection, so this is a must differential in our diagnosis. So the characteristic of the lymph node is usually at the cervical, supraclavicular, or at the axillary. And since TB infection is a chronic, thus the lymphadenopathy is also chronic and usually of non-tender. It is firm with discrete mass or matted nodes joined together. So the overlying skin may be indurated. So usually the pathophysiology of tuberculous lymphadenitis, it is of granulomatous inflammation in which lymph node will have a caseating necrosis. So next one. This is also the most common cause of lymphadenopathy, which is the cat scratch disease. So the cause is by Bartonella henselae bacteria, and it is transmitted by the cat's bite and cat scratches. So in HIV patients, since the patient is immunodeficient, so it may have a bacillary angiomatosis and peliosis hepatis. So as I have been mentioned before, cat scratch disease, it is a lymphocutaneous syndrome. So it must have the lymphadenopathy, which is usually localized to a draining regional lymph node, and it is tender with suppuration. And the cutaneous syndrome is usually of cutaneous papule presentation. So next. So for Kawasaki disease, the cause is mostly unknown, but it is also known as mucocutaneous lymph node syndrome. So from the name mucocutaneous lymph node syndrome, we know that there is a lymph node involvement in which when Kawasaki disease infection occurs, there will be a lymph node swelling. And so it means it has a mucosal changes, and the cutaneous in which it will have skin rashes. So the diagnosis, I'm sure everybody know about the diagnostic criteria. So the lymphadenopathy usually at the cervical area. So next one. So infectious mononucleosis. So infection mononucleosis, it has two causes, usually by Epstein-Barr virus, human herpes virus 4, or CMV. I will talk later. So between EBV and CMV infectious mononucleosis, so the presentation are quite the same, in which there will be a fever, pharyngitis, and also lymphadenopathy. So how to differentiate between these two causes? In EBV infectious mononucleosis, they will be presented with hepato and splenomegaly. So next one. In same cytomegalovirus infectious mononucleosis, it will also have fever, pharyngitis, and lymphadenopathy, but usually it will also come with headache and abdominal pain. Okay, next. Okay, for HIV, is transmitted by vertical transmission or by breastfeeding, and also by blood transfusion. So the presentation as stated, persistent lymphadenopathy, hepatosplenomegaly, failure to thrive, recurrent infection, and also developmental delay or regression. So next, leukemia. So for leukemia, it is one of the malignant causes of lymphadenopathy. So in children, usually the most common type of leukemia is acute lymphocytic leukemia. So they will have lymphadenopathy and also bone marrow failure appearance such as pallor, lethargy, easy bruising, bleeding tendency, and also recurring infection. They will also have hepatosplenomegaly, bone pain, and also testicular enlargement. Next one. Drug-induced lymphadenopathy. As the name goes, this lymphadenopathy is caused by an adverse drug reaction against certain drugs such as phenytoin, allopurinol, isoniazid, and also atenolol. So the presentation is generalized lymphadenopathy and will be presented with severe maculopapular rash. They will also have fever, hepatosplenomegaly, jaundice, and anemia. The next one is lymphoma. So we need to differentiate between Hodgkin lymphoma and non-Hodgkin lymphoma. So in children, usually a non-Hodgkin lymphoma is more common than Hodgkin lymphoma. So so usually lymphoma will be presented with B symptoms such as fever, night sweat, and also loss of weight. They will also have lymphadenopathy and also will have an involvement of mediastinal lymphadenopathy in which the patient may present with SOB and also cough. So how to differentiate between Hodgkin lymphoma and non-Hodgkin lymphoma? So Hodgkin lymphoma, the characteristic is the red Steinberg cell. So next one. So we move on to the approach to a patient with lymphadenopathy. The first and foremost, we need to take into account about the patient's age and sex. But usually, sex does not play any role in the diagnosis. Patient's age, why is it so? Because usually younger age patient may be presented with non-Hodgkin lymphoma, and older age may be presented with Hodgkin lymphoma. An example. So usually lymphadenopathy is not usually is not common for the parents to come with a complaint of lymphadenopathy unless it is very prominent in the child. So usually for the chief complaint, we have to focus on the chief complaint, whatever the parents concerned of, such as if the patient has a rash, might be suggestive of Kawasaki disease or drug-induced lymphadenopathy. So we need to take into account and ask about all the chief complaint related. And the lymph node. So for the lymph node, we need to ask about the site, whether the parents notice any multiple site or single site, the onset and duration of the lymph node, because for TB it is chronic, right? And for the characteristic, whether it is tender, whether it is warm to touch, and also any redness. So associated with other history, we need to ask about any scratch from cat and also any viral infection, such as pharyngitis. It might be diagnosed by Kawasaki disease. So any other associated symptom, as I have been mentioned before, for TB lymphadenopathy, we need to ask about TB symptom and so on. So for the red flags, next. So for the red flags, usually it is diagnosis of malignancy. So usually if we need to take into account any supraclavicular lymph nodes, any unexplained fever, any night sweat, any weight loss, any SOB, and also hepatosplenomegaly. So this might be suggestive of leukemia or lymphoma. So next one. So other past medical history we need to ask is about the immunodeficiency of the patient itself, and the birth history, and might be the mother have HIV, and also might be the mother does not have any knowledge about breastfeeding a baby and with HIV infection. So might be. And drug history, maybe the lymphadenopathy is induced by the drug, and also family and social context such as TB infections and also HIV infection, and also any siblings with leukemia. It will have an increased risk of the patient have leukemia itself, and any pet at the house, such as cat. So next one. Okay, so for the physical examination, generally the physical appearance such as pallor, jaundice or lethargy, we need to exclude any malignancy causes, and also throat and pharynx examination such as infectious mononucleosis or Kawasaki disease. Any rashes such as might be suggestive of Kawasaki, drug-induced or cat scratch, any conjunctivitis. And also for respiratory examination to rule out any TB infection. For abdomen examination, we need to examine for any abdominal tenderness or hepatosplenomegaly. So next one. So physical examination, since lymph node it is considered as under lump and bump examination. So these are the mnemonic for the lump and bump examination, such as 6 students, 3 teachers, and campfire. You can read this later. So move on to the investigation, how to investigate the patient with lymphadenopathy. So lymphadenopathy, it has many causes. So we need to take investigation in accordance with the diagnosis that we have in mind. So one of the investigation that can be done is complete blood count and peripheral blood smear, because in EBV, infectious mononucleosis, the patient might present with lymphocytosis with atypical lymphocyte. And also, patient with leukemia might have anemia and thrombocytopenia. Patient with Kawasaki disease might have anemia, leukocytosis, and thrombocytosis. Erythrocyte sedimentation rate is an inflammatory okay, so it might be elevated in Kawasaki disease. For coagulation profile, it might be abnormal in leukemia. For liver function test, it will have an increased ALT in drug-induced and Kawasaki disease. For renal profile, it might show AKI for drug-induced. And serologic testing can be done in EBV, Bartonella Hanselia, CMV, or any other infectious causes such as toxoplasmosis and so on. And blood cultures and sensitivity if we suspect an infection. And tuberculin skin test to rule out any mycobacterial infection. For HIV, DNA and RNA testing for HIV. Next. So serum lactate dehydrogenase might be increased in malignancy. Lymph node biopsy can be done in lymphoma to differentiate between whether it is Hodgkin lymphoma or non-Hodgkin lymphoma, and also bone marrow aspiration and biopsy for leukemia. So for imaging, we can do chest radiograph to rule out any pulmonary disease such as TB and also Kawasaki disease. Abdominal ultrasound such as hepatosplenomegaly. The ultrasound of the lymph node to look at the extent of lymph node and the characteristic of the lymph node. The CT of chest and abdomen to look for the extent of the disease, and also nuclear medicine for lymphoma. Okay, next. So how do we manage patient with lymphadenopathy? So basically, for the management, lymphadenopathy is depends on the cause. So we need to treat the cause. But for cervical lymphadenopathy, without any signs of acute inflammation, it usually will regress within 2 to 3 weeks. So example, for acute suppurative cervical lymphadenitis, we can give penicillinase resistant penicillin of first generation cephalosporin. And also we can, for Mycobacterium tuberculosis, we can give antimicrobial drugs for 6 months. These are the example of the treatment for the cause. And the first and foremost, we need to identify the red flag of lymphadenopathy. So I think that is all for lymphadenopathy. Is there any question?
Alright, thank you, Ijati. This one very clear explanation. Just little bit some addition about the generalized lymphadenopathy usually will involve both set of diaphragm, above and below diaphragm, because sometimes it will be multiple regional lymphadenopathy. For example, on the right cervical and then on the right axillary. Actually, it is not generalized, not really generalized. Maybe there are two possible causes from the cervical, for the cervical and then axillary. But if it is involve both side of diaphragm, it is clearly generalized lymphadenopathy. Okay, and then the approach is to establish the diagnosis kan. So what are the causes? Itulah infection, malignancy. What are the common usually for infection? TB, can be EBV, can be IM, can be what is yang acute cat scratch disease, as well as malignancy. Malignancy usually lymphoma but usually more common leukemia. Okay, others can be actually also some systemic immunologic diseases like SLE pun boleh ya. Alright, any questions? The important part is the investigation actually because we need several investigation to establish the diagnosis. Ada tak Isati you present any indication for biopsy, because not all what we call it lymphadenopathy we need biopsy. There are indication actually. Ada tak?
I'm sorry, doctor, I didn't.
Tak usually criteria of biopsy should be yang memang through increasing in size progressive satu. Second size usually more than 2 cm if 1 cm or less we don't consider to do biopsy at the moment usually we observe first if it is small in size less than 2 cm our first choice observe whether it's progress or not. So we deal with time lah. If it is not progressive, but more if it is shrunken or disappear, it is good lah. Because some of the acute causes like cat scratch disease, once the disease resolve, the lymphadenopathy will also resolve. Usually we do biopsy to in chronic condition and progressive and large. Or another yang indication tuh kalau supraclavicular Kalau supraclavicular lymphadenopathy, there is a risk of mediastinal mass kan. So we afraid of the obstruction from there, so we do biopsy lah. Okay. The another common situation is how do you deal with the biopsy? Do you prefer open biopsy or fine needle? Boleh jawab tak Isati?
I'm not sure, doctor.
Tak sure juga. Usually kan most likely choices is open biopsy because we can get exact volume and mass too. Because fine needle tuh risk tuh dia akan fail kan, dia akan kalau tak not on the mesh betul dia akan fail to get the sample. And then sample pun very small size kan kalau fine needle only based on our needle tuh. But biopsy sometimes relatif ya, not absolutely, relatively contraindicated. Kalau in case macam TB, actually better to do fine needle karena because if we do open biopsy, usually in case TB ini dia akan difficult to heal the lesion. Tapi actually even though not well healed pun after we confirm the diagnosis, after we start the TB treatment usually akan resolve juga. When the TB resolve, the wound will heal properly. Lagi ya, ini ada question nak tanya apa-apa?
Dr. Maidin nak tanya regarding drug-induced lymphadenopathy. So if the patient has drug-induced lymphadenopathy, do we stop or suggest an alternative drug?
Ada tadi in presentation.
Ada dia present
coba
course.
Izati.
For drug-induced lymphadenopathy, the first and foremost we need to withdraw the drugs. And if there is any symptom, we need to give corticosteroid.
Okay, good. And of course kan we stop the drugs, but usually sometimes kan it is chronic illnesses kan, like epilepsy that need phenytoin. So after we stop phenytoin, we need to introduce other anti-epilepsy lah. Kalau we stop, don't give any anti-epilepsy, nanti pasien jadi intractable seizure pula, jadi we call it long seizure tuh, status epilepticus pula. So we need to introduce other drug lah, alternative drug. And then maybe need steroid lah untuk tadi kan, to reduce the size, to stop the inflammatory reaction juga. Apalagi itu allopurinol saya pun tak tahu apa alternatif. Kalau tak boleh allopurinol, patient gout hyperuricemia. Kalau isoniazid ya part of TB treatment ya, we have other drugs kan. Atenolol boleh tukar yang lain, nanti hypertension. Alright.
Thank you, Doctor.
Okay. Tadi go back aja untuk yang observe tadi. Usually kalau acute lymphadenopathy, after we approach to get the causes, kalau dia infection, usually kalau acute infection, we usually treat with antibiotic kan, commonly. Usually kalau non-specific infection ya, with antibiotic that kalau community acquired ya, kalau yang sensitif to antibiotik itu within 2 weeks, sometimes pun 1 week pun dah resolve ya. At least dia akan smaller in size atau stop the progression. Usually kalau like this and after we give antibiotic 1 to 2 weeks, no progression atau dia dah resolve the infection, we don't do anything ya tadi. Dan dia akan persist we observe ya. Observe tu is sometimes need long duration. Sometimes sampai 6 months, ada yang sampai setahun baru hilang, ada yang sometimes setahun pun dia aja mengecil tapi still persistent. But as long as it is not progress, the size pun minimal, less than 1 cm, just sometimes we just observe ya, don't do anything. The one that we need investigation tadi itulah indication for biopsy ya, we do also other investigation ya. Don't forget MVP. Apalagi tadi the investigation yang lain. Usually yang initial tu ya we do MVP lah. MVP we can get both infection and malignancy features from there ya. Dan yang others ni yang specific for the diseases. Alright. Any more questions? Okay, thank you, Jati. Next.
Thank you, Doctor.
Welcome.
Okay. Next will be me, Muslihana binti Muzakir with metric number 1519824. Okay, so I'll proceed with child with hypertension. So although hypertension in children might although it's general, yet it is important because epidemiologically, in units, the incidence occur is 1.3, while in children and adolescent is 13.4% based on the CPG. So next. So so for children, it's rarely that they present in emergency department, but they might present in emergency department. Usually, they will the child with hypertension. We will monitor in the ward. So what we need to uh, we need to have a good history, clinical examination, investigation, and also management for them. So next. So the difference between children and adults is their BP is depend on the age, gender, height, and also weight. So back to the important history. So from the important history, first we need to know the symptom that they might present it with. So because hypertension is something that we discover through bedside investigation, meaning we use the BP monitor, then we discover that they actually have high BP, but they might present it with symptoms like fainting, headache for children like more than 7 year old, or they can even present with convulsion. So for further history, we might want to ask about the family history of hypertension, renal disease. For medical history, if the patients have already had heart problem or renal problem. And then um, for antenatal, uh, the it is more common in neonates and infant with antenatal steroid, maternal hypertension, postnatal acute renal failure, and chronic lung disease, and also indwelling umbilical arterial catheter. So the catheter actually related to hypertension as they might be thrombus formation at the time of the line placement. So it is important to ask regarding the antenatal history. And then the risk factor. So risk factor that is associated with hypertension is obese, drugs, specifically steroid, um, coronary heart disease, recurring UTI. Recurring UTI can also cause increase in blood pressure. Patients with organ transplant and and any increase in intracranial pressure due to trauma, or even the patient might develop increase in cranial pressure because of the complication of uh, to increase in blood pressure. So they might have targeted organ failure symptom. So for each organ, like eye, they might have a hemorrhage. They might present it with blurry vision. Then for uh, For the brain, they might present with, as I mentioned before, headache and convulsion. For heart, they may have previously or they will developing left ventricular hypertrophy. So that is the pathophysiology of it. Okay. For kidney, they may have reduced in the function of the kidney due to the damaged artery of the kidney. So, okay, I think that's all for history. Then we go next to the okay, how? So BP measurement, who and when. So in children for more than 7-year-old, we will check the BP annually, especially if the patient, if the children is obese, and with diabetes mellitus, renal disease, or for patient with diabetes mellitus, renal disease, aortic obstruction, on medication, will have their frequent BP monitoring in their medical follow-up. And then for children less than 7-year-old but at risk of hypertension, so they will have a medical checkup. They will have the BP checkup in. They will have the BP reading for every medical checkup or follow-up. So the diagnosis of high blood pressure, hypertension, is made if the BP values in 3 repeated and different visit more than 95 percentile of age, sex, height, or more than 130 or 130 per 90 millimeter mercury. So next, for clinical examinations. So in the clinical examinations, so basically the examinations that we will do, it is related to the symptom, the cause, and the complications. So from the cause, so from the effect of the steroid use, for example, if the patient have underlying kidney problem, for example, nephrotic syndrome, that require them to take corticosteroid, they might have the sign of Cushing syndrome. So, as in the picture, they might have edema, and then balding, and then edema, facial edema, proximal muscle weakness. So they might have that presentation. And then for if the patient have heart disease, so we can do cardiovascular and also respiratory examination. And we need to do central nervous system examination in case of the patient develop complication of the central nervous system. And then fundoscopy. From the fundoscopy, we might find papilloedema and hemorrhage, or even exudate. So next, in the investigation, so from the investigation, I'll divide the investigation into 3. So blood, urine, and imaging. From blood, we can do renal profile, lipid profile, and fasting blood sugar to monitor the renal, of course, to know the renal function, whether it's still good or not. Then lipid profile, know the any excess of lipid, and then fasting blood sugar if the patient if we suspect the patient to have diabetes. And then for urinalysis, because we might want to detect any proteinuria and to know the GFR of the uh, the 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 function of the kidney. And then imaging, we might want to do renal ultrasound or even renal ultrasound to check the conditions of the kidney if the patients have a congenital problem. And then chest X-ray to look at if there is any left ventricular hypertrophy from the chest X-ray. So, okay, for management, next. Okay, for management, the goal is to achieve the BP level that reduce risk of target organ damage. So actually, the real purpose is to reduce the target organ damage, and then reduce the risk of premature atherosclerosis and early development of cardiovascular disease, because the earlier that we discovered that the patient have the risk for hypertension, the better. And then reduce risk of developing adult hypertension and metabolic syndrome. So for early management, for hypertension management in children, uh, uh, it starts with non-pharmacological, which include the dietary changes, and then promote exercise and weight reduction, especially if the children is obese. And it is recommended in all children with hypertension. And then the indication to start the medication is if the hypertension is fail with the lifestyle modification, and then if the patient have stage 2 hypertension without any modifiable factors, meaning like if the patient have family history of hypertension, and then the patients already have congenital renal problem, and then any stage of hypertension with the number 3 is any stage of hypertension with chronic kidney disease or diabetes mellitus, and hypertension with target organ damage. These are the indications. These are the indication to start the pharmacology treatment. And then the step care approach is, first step is we tried monotherapy, which require once daily dosing. And then if it's still not improved, then we increase the dose until the maximum dose based on that patient, because as we know, children, we really need to do detail in make sure the dose for each children according to the weight and the age of the patient. And then okay, after we increase the dose, if it's still not improved, then we add the second drug, and it is titrated with the initial dose with initial drug that we start, and the recommended group is thiazide group. And if the last step, if still not improved, then add the third drug of different class with the consultations of a pediatrician expert in childhood hypertension. So basically, if we had tried this step but still not improved, we should refer to the experts lah. I think that's all for my presentation. This is my reference.
Alright. CPG itu CPG yang adult kan ya? Yang 5th edition.
Yang adult tapi dia ada adalah few pages untuk children.
Okay. So actually yang the first thing to do kalau hypertension tu buat di table atau apa BP chart lah. Tadi ada tak?
Tak include BP chart.
Okay, because we don't have one single number of apa criteria of hypertension kan in children. We need the table atau BP chart. So because different age and gender and height will have different value apa of the BP ya. So kena ada apa table atau BP chart tu to determine lah whether your patient is hypertensive or not ya. So basically you memang definitely you need lah the table atau chart tu. So bukan 140/90 ya. So need the table or chart, and then must clearly apa namanya measure lah in proper position, proper apa namanya BP cuff, in the calm situation. Kalau lepas lari-lari pasti tinggi lah. So that's why memang kena need 3 readings in 3 visits kalau outpatient. Tapi kalau inpatient ya as long as 3 observation punya period ya boleh. Biasa kan observation tu boleh 4 hourly atau every shift kan. Dalam sehari tu we can diagnose lah. Okay. Tu. And then BP more than 95th centile. Ya. Itu yang stage 1 atau yang hypertensive lah. Actually more than 90 centile kita sebut pre-hypertension. Yang definitive hypertension more than 95th centile. Kalau dia more than 99 centile plus 5 millimeter mercury itu so patient is in crisis ya hypertension ya. Crisis hypertension is emergency situation because we need to reduce the BP immediately ya. But no normalize in at one time ya, kena reduce by 25% per day. So itu if not in crisis ya we establish the diagnosis, establish the hypertension, and then establish the causes. What are the diseases that cause hypertension? Because in children, unlike in adult kan 70% is idiopathic primary hypertension that might need long life antihypertensive agent. In children, most common is secondary hypertension, which is commonly is nephrotic kidney nephro problems ya, like AGN ke apa ya. So which is actually kalau like AGN it is is good prognosis ya, only few days dia akan resolve ya. So kalau resolve we just stop the antihypertensive agent. Okay, only need for temporary lah. Kalau acute and reversible, tapi ada juga condition like CKD yang maybe also need long life lah sampai patient develop sampai end state or sampai end of life. Okay, need to establish the diagnosis. So that's why our initial approach usually to diagnose the kidney problems ya. Check the UFAM, urine sample, and then renal function test, maybe QB ultrasound ya, kita tengok lah. As well as ya we step by step juga diagnose rule out any other possible differential diagnosis. Okay, treatment sama lah, more or less the same because the choices of antihypertensive agent sama lah with adult, but usually because kidney problem usually kan with edema, so our easiest choice we start with diuretics usually. If no edema, maybe calcium channel blocker, nifedipine. Actually, is inhibitor captopril is also useful in children, tapi lah issue in children tu because kidney problem tu usually ada possibility of renal artery stenosis. Usually nephrologist tu tak suka start with captopril dulu. unless kalau already rule out renal artery stenosis, because if there is RAS, renal artery stenosis, we give captable, dia akan worsening di stenosis tu, dia akan higher the BP nanti jadi crisis. Okay. Alright, any questions? Senyap semua ni. Yes?
The definition of a hypertensive crisis that you mentioned, 99 plus 5 millimeter mercury, is it the same with the more than 95 percentile plus 12 millimeter mercury?
Not sure. Usually I use yang 99 plus 5 tu. Yang 95 plus 12 tu kat mana reference ada?
Up to date.
Up to date ada yang maybe more or less the same kot.
Okay, that's it. Thank you.
Okay. Okay. Ada questions? Ada? Abdullah Harif ni biasa tanya-tanya, senyap je. Ada yang banyak yang double-double ni. Ni ada 2. Nampak je ramai student tapi double semua. Saki tak tanya tidur lah. Yang tak ada gambar ni, tidur semua ni. Yang dah dipanggil tak menjawab ni. Tak ada yang buka video. Macam mana ni all ni? It's up to you. Kasihan yang present lah saya. Dah tengah hari mengantuk, saya pun mengantuk. Tapi you should appreciate the presenter lah. Kasihan lah yang present penat-penat. You tinggal tidur pula. Tak ada pun. Alright. So okay lah. So start yang last. Farah ya. Farah kan Zulaiha panggil tu.
Farah boleh.
Farah je.
Farah pun boleh. Okay. So, Bismillahirrahmanirrahim. So, my name is Farah Zulaiha Ahmad Zainuddin, 161-8978. So, I'm going to share with all of you regarding child with rash. Okay, so as all of us have gone through dermatology, right? So, we are very familiar with all of these terms. So, just to revise it a little bit. So first is macules. So as you know, macules is a non-palpable lesion less than 1 centimeter that vary in pigmentation from the surrounding skin. So it is different with patches in terms of size. When we call it as patches, then it means that it is more than 1 centimeter. Okay, and next is papules. So papules are palpable, discrete lesion less than 1 centimeter. And plaque is a raised, or we could call as a plateau, that are more than 1 centimeter in diameter. And next is nodule. So it is a palpable solid cystic discrete lesion measuring between more than 1 centimeter. The telangiectasia is actually the dilated superficial blood vessels. And next is purpura, or we can also call as hemorrhagic rash. So it is a red purple lesions that do not blanch under pressure, resulting from the extravasation of blood from cutaneous vessels into the skin. And it can actually be macular or raised, means that like palpable purpura. And next is pustule. Pustule is quite similar with vesicles actually, however it contains purulent material. Next is vesicle. It is less than 1 centimeter. It is small. Hemorrhagic contain clear serous or hemorrhagic fluid, while for bulle it is larger than vesicles. It's more than 1 centimeter. Next is wheals. So wheals is an irregular shape, elevated edematous skin area that may be erythematous or paler than surrounding, as you can see from the picture. Next is escoration. So escoration is it is due to scratching actually. So it is a complete loss of the partial or complete loss of the epidermis. And next is leisionification. So leisionification actually result of chronic inflammation, like you can see in patient with atopic dermatitis. It is hard thickening of the skin with skin marking. Next is scale, superficial epidermal cells that are dead and cast off from the skin. And then crust. Crust is due to dried exudate of serum, blood sebum, and pleural material. And fissure is just a deep skin split extending into the dermis. Different with erosion, while erosion is just superficial focal loss of part of the epidermis, and the healing does not result in scar. However, for ulceration, the healing will result in scar due to loss of not only epidermis but also extend up to the dermis. So how can we classify rash actually is between primary lesions and also secondary lesions. So primary lesions, it just means that the rash itself represents the initial pathological changes like macules or patches, papules, plaques, vesicles or bullae, pustules or wheals. However, for secondary lesion, it represents evolved changes from the skin disorder due to secondary external forces such as scratching or picking or infection or healing due to infection like for example, in atopic dermatitis, you can see lesionification, excoriation, and scaly skin. Okay, so I've already divided it into type of lesion, let's say maculopapular, vesicular, bullous, or pustula, as well as pedicate and purpuric. So most common cause of it is infection actually. So I've divided into either viral, bacterial or others. Others mean other than both viral and bacterial. So as you can see, I will go through a little bit of some of the diseases later. So there is also a term called as urticaria rash. So as we know, urticaria means something which is, as I mentioned just now, right? It's a raised lesion, it's itchy. So it can be due to bacteria like mycoplasma infection, viral causes like enteroviral, adenoviral, EBV, hepatitis, or HIV and Lyme diseases. However, we are more common see it in those with allergy reaction, vasculitis, malignancy, and idiopathic. So how do we approach for patient that come in with rash, for child that is having rash? So by history, physical examination, investigation. So from the history, what we should know from patient is actually their background, their age as well as their sex. So it is important for us to know our status of patient. And next is rash. So rash, we can further divide it into characteristic, pattern of distribution, timing and onset, duration, changes in morphology, initial appearance, and how it has evolved, and aggravating factors. So I'll go through one by one, yeah. So for the rash, as I mentioned just now, we can actually classify it according to its characteristic, whether it is maculopapular, vesicular, bullous, pustula, and pedicate, purpuric rash. However, mind you that some of the diseases came in with polymorphous features, means that it has multiple type of rash at the same time. For example, have all three maculopapular and vesicular rash in chickenpox, for example. So I'll go through it later. So next is pattern of distribution. So we can actually predict what type of disease this patient have based on the distribution of the rash. So if it's widespread, then think of atopic dermatitis or psoriasis or scabies, drugs, as well as urticaria. If it's centrally located, so think of psoriasis versicolor or any viral exanthemata. So exanthemata here, just to refresh, exanthemata is skin lesion, while enanthemata is the mucosal lesion. Okay. So next is peripheral. So peripheral, you can think of atopic dermatitis, herpes zoster, psoriasis, insect bites, as well as warts. For specific areas that are affected, for example, only at the face area, this patient can come with just lesion at the face area. So we might think of more localized pathology such as impetigo, or could it be atopic dermatitis, especially in infants. They have it started to be at the face as well as at the extensors. And then photosensitive, like in mala rash, in SLE, could it be acne because of puberty, for example, and viral exanthemata. And then is scalp. For scalp, think of tinea, chickenpox, pediculosis, and seborrheic dermatitis or folliculitis. If it's occur in flexures, especially in children that already past their early childhood. For example, in atopic dermatitis, you think of atopic dermatitis as well as tinea. And next is nails. So if there's any pathological changes of the nails, then we can also think of if it could be fungal infection of the nail, such as tinea, as well as dermatitis. If it's occur in the penis area or other genital area, so it could be scabies as well as genital herpes and warts. So you can also look by their timing and onset of the rash. So if it's acute, then think of something that is acute, such as urticaria, allergic contact dermatitis, insect bites, drugs, or viral exanthemata. If it's chronic, then think of something that is think of chronic diseases such as atopic dermatitis, psoriasis, and fungal infection like tinea or pityriasis versicolor, and warts. If it's in between, like acute to chronic, which is between days to weeks, then think of also both acute and chronic causes like atopic dermatitis, scabies, impetigo, and fungal infection. Next is the rash. So as I mentioned, there are some diseases that have multiple type of rash at the same time. For example, scabies, HFMD, and chickenpox can have maculopapular, as well as vesicular rash. So, if in this condition, then we need to look at the classical sites. Yeah, for example, in scabies, think of classical sites such as in interdigital folds, wrist, elbow, umbilical area, and genital area, as well as feet. For HFMD, by the name per se, hand, foot, and mouth diseases, so we need to look at the hands, the feet, as well as buttocks and legs. If it's chickenpox, then usually it begins starting from the trunk area, and then it will follow by the head, face, and less commonly the extremities. And next is macular rash. So macular rash, such as measles, it begins on the head, usually above the hairline, and spread over most of the body. It means that it starts from capillate to caudal. While popular rash, such as scarlet fever and molluscum contagiosum. So scarlet fever is started at the trunk, underarms and groin, and that is spread to the extremities. And the classical feature of scarlet fever would be sandpaper-like. If it's molluscum contagiosum, it can occur any part of the body except for the palms and soles. So we need to look at the attributes of the rash itself. For molluscum contagiosum, it is more firm, dome-shaped, pearly, shiny, and with central umbilicus. So if it's maculopapular rash, both of macules and papules, so think of rubella or roseola infantum insect disease and Kawasaki disease. So for rubella, it begins on the face and it spread to the body. So rubella is also called as 3 days measles because it just lasts for 3 days and it is less prominent than measles. So this can be comparative with measles itself. So for roseola infantum, so the rash is coincident with the effervescence. So it starts after the patient resolves the fever. So it starts from the neck and trunk and then spreads to the extremities. For Kawasaki disease, as we know, it is usually at the truncal area. And next is hemorrhagic rashes. So how can we differentiate between HSP and meningococcal? Is that HSP is a non-blanching palpable purpura and PTK and ecchymosis. So the location is specifically at the gravity pressure dependent area. However, for meningococcal infection, meningococciemia, so it is a non-blanching PTK and frequently found on the trunk and lower portion of the body. Okay, and next, we can also classify rash whether it is itchy or not. So, for example, in itchy rashes such as urticaria, atopic dermatitis, scabies, insect bites, chickenpox, and tinea and psoriasis, and often not like warts, tinea, impetigo, and other viral exanthemata. So we need to, besides the rash, we need to dig more regarding the history by knowing the associated symptoms. So most common associated symptom that occur with rash is actually fever. So fever can indicate infection or inflammation that is going on. And next is pain. For example, in shingles, pain at the rash site. And next is if we suspect allergy, and then we need to ask further regarding the possible triggering factors or allergens that has been contacted by patients. And then systemic reviews to find other clues. Yeah? It depends on the disease. If we think of HSP, then ask about joint swelling, pain, abdominal pain, melena, and also hematuria. If it's ITP, then think of if there's any bleeding tendency or easy bruising. If it's measles, then we need to know the classical 3 Cs, which are the prodromals, consist of conjunctivitis, cough, and coryza. If it's urticaria, then think of wheezing or stridor, allergic reaction. And then for atopic dermatitis, think of other atopies such as asthma, allergic rhinitis, and conjunctivitis, as well as previous eczema before. And we need to also know about the past medical history. Does this patient has previous history to chickenpox? Because second time of chickenpox, it could be shingles. And next is history of atopy. So ask about, as I mentioned just now, and immunization history, about MMR vaccine and other recent vaccination, because it could be a manifestation or a reaction towards a vaccine. And next is drug history. Ask about any drug or food allergy or any recent medication that patient took. For family history, ask about family history of atopy and other skin diseases. Or for social history, ask about patient's hygiene and similar lesions among family and friends. If this occur, then you might think of infective causes. Any history of traveling, dengue-prone area, outbreaks, or water and recreational activities, it is more towards infective cause like dengue, leptospirosis, and next, we go to physical examination. So for physical examination, of course, start with general condition to look at patient's hemodynamic status, respiratory stress, consciousness, and alertness level. However, what we want to look more into detail is actually the rash. So we need to inspect all possible areas for rash, all skin, oral mucosa, hair, as well as nails. So we need to know type of the lesions, as I mentioned just now, location and distribution, arrangement, as well as shape and color. Next, if it's possible, then we can do palpation. We want to feel whether it is palpable or not, whether it is blanched or not, whether it is thick or not. We need to feel the surface. And next is systemic examination to look based on our differential diagnosis. It will guide us towards our systemic examination. Whether we want to do abdominal examination like in HSP, or we want to do musculoskeletal examination like in acute rheumatic fever, etc. So I have already classified it into vesicular, bullous and pustular rash, macular rash, as well as hemorrhagic rash. So the slides after this are basically just pictures. So first we go to through to scabies. So scabies is very common in childhood. So and it is basically it has its own classical areas, which consists of the sites over here. As you can see, the armpits, the umbilicals, the genital area, the knees, and the fingers, the hands, the wrist. Okay, so it is a red excoriated papules, nodules, vesicles, and pustules, as you can see from the picture. And next is hand, foot, and mouth disease, HFMD. So it has both enanthum as well as exanthum. So enanthum is basically at the hand and foot, exanthum basically at the hand and foot area, and enanthum at the mouth area. So at the mouth area, you can see erythematous macules, vesicles, and then it ruptures and it will form a superficial ulcer, as you can see from this tongue of this boy. And next is for exanthum. It is more like maculopapular. This is maculopapular as vesicular macular rash. Okay, it is polymorphous rash at the same time. And next is chickenpox and zoster. So rash for chickenpox is red, is that oval teardrop vesicles, and next it will ulcerate and crust and heal. For zoster, however, it is located along the dermatomal area. Okay. Next is maculopapular rash. So it's a measles. So as you can see from this boy, this very obvious, right? The rash it begins on the head, above the hairline, and spread over most of the body. So it start from cephalate to cauda. So it rarely involves the palms and sole. it might come with petechiae or hemorrhagic in this case of black measles. And then during the prodromal time, which is before the rash set in, so patient usually will complain of three C's, like conjunctivitis, cough and coryza, as well as we can observe coplic spots, grey, white and sandy grain-sized dots on buccal mucosa. However, it appear about 12 to 24 hours. And the rash basically are maculopapular rash. So as the rash fades, it becomes brownish, discoloration and desquamation. However, I would like to draw your attention to this picture over here. So this picture is actually a real patient of that I saw during my family medicine posting. So this patient is actually, if I'm not mistaken, 2 to 3 years old boy, came in with a history of the 3Cs as well as rash. So however, if let's say that we expect it in our back of the mind to, we expect it to come like this, right? Macam textbook punya looking. However, patient usually come not like the textbook pictures. So even this kind of rash yang tak nampak sangat pun, it is actually measles. So it is true that this boy actually contacted friends having measles dekat daycare lah. Okay, and next is rubella. So rubella, rash, erythematous, maculopapular, discrete rash, and rose color spots on soft palate. We call it as Forchemé spots. Next is erythema infectiosum. So erythema infectiosum also called as slap cheek rash because the rash appears at the cheek. And erythematous symmetrical maculopapular truncal rash, and it is a reticulated or lacy rash. Next is Roseola infantum or 6 disease. It's a maculopapular rose-colored rash. It can also come in with Nagayama spots over here. So it occurs erythematous papules or mucosa, soft palate and plate of uvula. Next is Kawasaki disease as mentioned by our sister Izati just now. So I don't have to repeat it again. Next is scarlet fever. So scarlet fever, the classical feature would be the white strawberry tongue. The rash is a blanched papular rash in sandpaper-like. It has a pastia line. Pastia line is this one. So pastia line found in folds of skin such as neck, antecubital fossa and groin. And then patient can also have desquamation after the rash resolves. Next is molluscum contagiosum. So molluscum contagiosum, as mentioned, it is a firm dome-shaped papules, pearly, shiny surface with central umbilication. So this picture is also a picture that I took from HTAA ward during my pediatric posting in 3rd year. So this patient is actually an orang asli girl. I can't remember the age. She came for other disease. However, I found out that she actually has molluscum contagiosum. As you can see, this is a pearly, domy features of suggestive of molluscum contagiosum. Next is vesicular bullous and pustular rash. So like Henoch-Schönlein purpura. So it is a palpable purpura without thrombocytopenia or coagulopathy. And then patient can also come with other features that suggest for Henoch-Schönlein purpura, such as arthritis, arthralgia, abdominal pain, and glomerulonephritis. Last but not least is meningococcemia. So meningococcemia is a non-blanching petechiae, most frequently on the trunk and lower portion of the body. So you can test it by pressing a clear glass to see whether it blanch or not. It's a blanch test. And petechiae can coalesce into large purpura and form ecchymotic lesion like this. And next is investigation. So investigation is actually depend on our judgment whether we want to investigate it or not, because usually the diagnosis is based on our clinical findings. So for investigation is FBC, we can to know whether it is an infection or allergy reaction, then it could raise in total white cell, hemorrhagic rash and low platelet. So for specific rash such as scabies and tinea, we can do skin scraping and then we examine under the light microscope. For viral exanthemata, we can confirm it by sending for specimen culture like throat swab or blood, urine or stool for PCR or ELISA. If it's acute rheumatic fever or scarlet fever or bacteremia, we would want to do a specimen culture of throat swab and blood for culture and sensitivity. For acute rheumatic fever, you want to do ASOT, anti-septicizing titer, and then atopic dermatitis or contact dermatitis or allergy, we want to send for allergy skin testing. And then for treatment, first of course stabilize patient if patient came in with if patient came in to you, especially at the emergency department, not the outpatient clinic. And next is supportive treatment to ensure good hydration in patient. And next is for symptomatic treatment. So if patient is feverish, then we give antipyrexia. If it's itchy, then we can give antipruritic such as antihistamine. And to isolate for infectious diseases like measles and others, and to notify the pejabat kesihatan daerah if it's notifiable diseases such as measles, and to treat the underlying disease. If it's viral exanthemata, so usually most of them are self-limiting except for certain cases that might need antivirals. And then for bacteria, need to give antibiotics. If it's immunological reaction, such as ITP, for example, so it might need IV immunoglobulin and anti-inflammatory. So we treat according to the cause. So these are my reference. Thank you very much. So this is actually a picture of us back then during our third year. So we hope that sooner or later we can go back to UIA.
InsyaAllah.
So
Next week kan? Next week belum confirm
not all, Doctor.
Yang ini kan, yang apa, non-red zone kan, balik. Yang red zone berapa ramai kat sini? Yang pitch ni.
Berapa Zati?
Yang from red zone.
9 orang.
How many?
9 people.
9. Mainly KL Selangor lah.
KL Selangor ada seorang kat KK.
Sorry, ada berapa?
Ada seorang dekat KK, tapi mainly semua dekat Semenanjung.
Nah, apa orang Sabah ni balik pula? Siapa yang kat Sabah ni?
Hani.
Dah lah tahu kat sana banyak kes yang balik sana pula. Actually you coordinate lah with academic office. Actually kalau naik my suggestion actually yang red zone tu you karantin 2 minggu and then swab lah. Tapi lah swab tu kalau you bayar sendiri tak tahu. And actually you can ask academic lah whether UIA can bear the cost. Actually kan you will be swab in Sasmek. Kena tanya Sasmek punya manajemen juga lah, Prof. Taufiq atau siapa, Dr. Niknon juga lah. Mereka boleh bantu untuk swab 9 orang atau ya semua lah, semua year 5, year 3. I don't think dia akan sampai 100 orang. Quarantine 2 weeks and then swab. Kalau negatif kan akan be release. Alright. So go back to the discussion. Rash ni pun dulu pun masa year 3 pun dah banyak topik topik seminar pasal diseases kan, yang infectious diseases tu. Usually kan tadi approach yang penting ya rule out yang severe condition dulu. Kalau with meningococcemia kan usually patient with in critically ill condition we need to resusc and admit patient in ICU ya. Most likely patient kan stable ya. Patient stable tu nak senang juga is roll out the hematologic dulu, hemorrhagic rash kan, hematologic problem whether it petaihi, purpura or ecchymosis kan. Usually case-case yang hemorrhagic problem ni kan the bleeding and will be non-blanching. The common ya vasculitis lah, SSP. Kalau petaihi ya ITP lah kan. So simple kan, just check FBC. Apalagi yang lain ya, yang hematologik ni. Okay, as long as it is non-blanching, check the SSP, ITP or other common hematologic disease. Okay, settle. Kalau it is blanch rash, kalau you tekan-tekan dia hilang, jadi so merah keras kan only apa namanya, macam inflammatory reaction je lah kan. So big group tadi ya, sama lah, ada maculopapular or vesicular lah, can be bullous, can be pustular, tapi yang senang yang maculopapular or vesicular ya. So nanti kalau you dapat case tuh, differential diagnosis kan usually clinically we can give professional diagnosis, but usually we should list down differentials kan. So jangan campur ya. Yang grup maculopapular jangan, kalau you jumpa pasien maculopapular jangan letak vesicular, for example chicken pox. Nah, kalau pasien ada vesicular rash jangan letak macam measles, jangan campur ya. So kena ikut grup nih ya. Maculopapular ya list down ada berapa nih, contoh yang from this slide ada 1, 2, 3, 4, 5, 6, 7, 8, 5, 6, 18 or 19 kan, so many ya, but usually ya list down at least 3 or 5 pun udah cukup. Ada karakteristik kan, dan most common memang dia viral exanthem kan, exanthem due to the viral infection dia with fever, non itchy. Karakteristik kalau macam measles kan yang unvaccinated child usually less than 9 months ya yang kerap. Kalau yang anti vaksin sampai 5 tahun pun ada juga ya. Atau in hari itu yang orang Asia yang gua musang tuh dia not well covered ya, vaccination. Measles dia ada Copic spot yang 3C, and then the rest develop when the patient still having febrile phase, masih demam ya. Kalau yang similar feature of rash, and actually rash ini kan you with your experience lagi banyak tengok the case akan easier kan. Yang measles and yang dekat-dekat tuh measles like kan, yang Roseella infantum tuh. Yang measles like nih, Roseella infantum nih dia infantum ya karena most likely in infant, atau lagi satu ya exanthema subitum atau 6 disease nih. Ya actually after fever subsided baru develop rash, and sekejap aja. Kalau measles dia more longer ya. And usually there are many complication, can be diarrhea, IgE, can be pneumonia, and so on and so forth. Oke, lain rubella, and then apa lagi ya? Yang 56, and then be careful yang bacterial, scarlet fever, and maybe Kawasaki ya yang common. Need to establish the diagnosis. Kalau yang vesicular, ya usually chicken pox. Kalau yang start from the face and trunk, kalau herpes yang most likely ya labialis ya, ada genitalis, tapi genitalis itu not in children ya, unless memang poor hygiene memang boleh juga genital herpes. Usually genital herpes kan in adult, in children usually labial herpes ya, dekat-dekat mulut dia sampai bengkak, biasa dia sampai crusted lesion. Be careful SJS ya, history of drug allergic reaction. SJS ini karakteristik dia kita sebut mucocutaneous juga kan. Dia involve the mucous, dia ada conjunctivitis, ada letak oral mucosa, painful masa urination juga. But usually karakteristiknya memang after taking some medication lah. Oke, apa lagi ya? Kalau kronik eczema yang lain kan cerita dia kronik. PBS usually karakteristik juga itchy, and then highly transmitted ya, in family atau in dormitory. Mahalah ada tak yang kena ni. Kira semua simple je, just how to establish the diagnosis ya, can be clinical based on experience, but sometimes you need investigation. Okay, any questions? Dah 3:30 ya, 3:25. Yang lain senyap semua ni. Tadi dengar Badrul dan Zaki dah dipanggil tak keluar. Tak ada yang last week kan saya suruh open video, semua open. Sekarang tak nak buka video semua. Syarifah, Syahmi mana ni? Aisyah, Safia. Ini Safia ni. Belakang saya ni Safia juga. Apa? Nurul Fitri, Akila, Ifa, Nur Farah, Afika, Faiz, Azira, Hana, Hani, Haikal. Ada Farah Syahira pula. Farah Syahira mesti join. Anis, Amirul, Amira, Hamil. Mana ni orang? Oh, Abdullah keluar pula video. Ini kat rumah ni. Kat rumah kan? Belum ada yang sampai Mahalah kan? Actually suruh datang Mahalah hari Isnin juga ke hari Ahad?
Hari Isnin.
Isnin pula, nanti lambat pula. Tak boleh teaching kan? Isnin tu next week your schedule dah set kan? Belum Tak ingat jadual.
Izati, next week Isnin we should be having a BST with you,
itulah kan. So, kalau baru sampai kan?
Itulah.
Datanglah hari Ahad.
Tak boleh dia register
hari Isnin. Kena register hari Isnin lah. Tak apalah, nanti postpone lah yang Isnin.
Okay.
Ini tu lah. Actually even yang from green zone, yellow zone, you kena pastikan you are asymptomatic. Tak ada kontak kan you all. Kalau you kontak, you kena your first reaction ya, you kena isolate yourself lah. Jangan sampai bawa your disease to orang lain pula. Isolate, quarantine, and then test lah kan. Kalau kontak kan you report tu KK atau under KKM punya jurisdiction kan, you will swab kan. Tapi itulah yang yes.
Oh sorry, Dr. Wat, apa plan department untuk orang yang tak boleh balik?
Yang tak boleh balik, plan ya tak. Macam mana ya, you boleh je join online, tapi you just dengar je kan. You nak present ke siapa? Saya pun tak tahu. Patutnya itu you propose lah. Batch leader ada kat posting apa? Siapa batch leader? Saya kenal tak? Bukan Abdullah Arif ya? Siapa?
Saya Syahmi Yahya.
Syahmi ni batch leader ya? Semua. So you negotiate lah with Prof. Marzuki lah. Maybe hari ini dengan esok masih busy kan Final Pro. Kamis petang lah you contact.
Actually Doktor,
yes.
kita orang dah negotiate dah and we already sent an official letter to Prof. Marzuki and Prof. Samsul. However, they insist that from red zone area memang tak boleh balik.
Itulah you propose quarantine and swab tak boleh juga.
They don't want to. I think they don't want to take the risk as well as kalau swab tu kena buat sendiri lah.
Itulah kalau quarantine and then swab under UAE patutnya boleh tu. Entahlah. Because you are a student kan. UAE patut jaga. Kalau mereka tak nak ya swab sendiri kok. Another option. Kalau you swab sendiri tapi quarantine tu kena declare juga. Kalau ada yang agree tak apa, will accommodate lah. You datang quarantine, tapi quarantine pun kena report ke Prof. Samsul juga. Macam mana nak arrange quarantine. Itulah kalau akademik dengan yang Dean's Office tak nak accommodate dia ya terpaksa kan departemen ya kena ikut lah kan. You all tak boleh datang. Yang 9 orang online ya boleh je yang masa biasa teaching you salah satu atau 2 orang buka the link. So yang lain dengar je lah kan. Kalau nak present you pun tak ada case kan. Dulu saya masih rajin carikan case kalau sebab semua online kan. Sekarang kan nak biasanya yang sampai kuantannya yang dapat case. Nak tunggu sampai bila? Berapa? 9 tuh yang selang apa KL Selangor 8 tuh, yang satu KK. Kayaknya. Iya.
Betul.
Yang posting lain ramai juga. Total berapa Sami?
Dalam satu batch ada 43.
Oh, itu ramai lah. 5 posting kan. So, yang paste nih sikit juga maknanya 9. Ada yang lebih dari 9 kan. Entahlah, itu apalah kalau apa itu university punya rule ya ikut aja yang online ikut apa just dengar aja. Exam ya kita tak boleh bar you from exam kalau you dengar online macam tu. Kalau you tak datang kita bar lah. Kalau you tak ikut online mana you absent kan. So, maknanya automatic bar for exam mana you kena. Kalau hanya for this block kan nanti you masih boleh dapat 4 block. By rule you can still sit for final pro. Entahlah, nanti akademik pun tak boleh fikir panjang tu memasuki dengan assumption. Patutnya usually different kan yang even from KPT pun yang apa suruh online kan ya, kalau apa non clinical kan clinical actually have apa right to do face to face session, unlike yang apa nama yang non clinical memang tak payah face to face kan. Kalau you all tak face to face ni macam mana nak dapatkan passion, nak dapatkan experience, skill. Apa lagi ya nak bantu. Ya itu kok kalau rasa kalau yang dah itu buat you all memang tak boleh. Kalau bayar sendiri kan ada yang ada duit, ada yang tak ada duit. Kalau ada duit bayarnya sendiri lah semua. Alright, anything? Tak ada? Dah ya? So, ya tak apa nanti. Kalau yang group leader Sami juga?
Izati.
Oh, Izati. Nanti apa-apa boleh je text saya kalau ada update-update. Atau Dr. Syed Halik kan. Dia pun rajin apa monitor you all. Okay. Okay, with that we close our session with us speaking for an answer. Okay, thank you all. Good luck. Hopefully berapa ramai? 28 kan Yon? Ke 27?
28.
So 19 we will meet 19 of you by next week lah. Yang 9 KIV dulu ya. Alright. Yang 9 itulah yang group friend tolonglah untuk open je apa the handphone buat satu link meeting masa every session. Tapi balance tak 3 grup nih 9 orang nih? Grup berapa yang paling lama hilang? Ke sama-sama 3 hilang?
Grup 2
Grup 2 ada 5 orang tak ada. 5? 5 ke 4?
Farah pun balik lambat juga.
Balik lambat kenapa?
Farah explain.
Sebab saya kuarantin. Jadi bila kuarantin dia kena cukup 14 hari.
Kuarantin
so, saya
Farah ni
sampai...
kat mana? Kuarantin kan ada kontak ke?
Saya kuarantin dekat Perak.
Close kontak lah. Finish kuarantin tak apa. You
Tapi
kena swab juga kan?
Lah.
Okay, tak apa. So tinggal 4 orang grup tu. Grup tu mentor siapa?
Datuk doktor.
Inform lah. Lagi pening dia. Hari tu dah marah-marah dia buat online teaching. Buat you all tak tahu case kan. Bukan tak tahu ya, memang bukan your case kan. So kita decide untuk seminar. Yang grup 1? Grup 1 berapa? Tak ada.
Ada 2 orang.
So 2, 5. So yang lagi 2 grup 3 kan? So grup 1 dengan grup 3 7 kan maknanya. And then grup 2 yang paling teruk. Oke lah. Nanti boleh je text nanti by Isnin atau by this week pun nanti kita buat ada meeting juga hari Jumat. Jumatnya ada meeting. Alright. Okay, thank you. Assalamualaikum.
Thank you, doktor.
Thank you, Doktor.
Hai Kal.